Okay, good night, everyone. I'm Dr. Christian Bisessa. I'm one of the junior office officers in the San Fernando General Hospital Neurosurgery Department. And tonight I'll be presenting on pineal gland tumors and pineal region lesions. So just going to talk briefly about the anatomy of the pineal gland. So the pineal gland or the epiphysis is a small cone-like structure that comprises part of the diencephalon. It is a neuroendocrine gland that secretes the hormone melatonin, which is responsible for maintaining the circadian rhythm and regulating the sleep-wake cycle, as well as several other polypeptide hormones that have a regulatory function on the endocrine glands. It is bounded dorsally by the splenium of the corpus callosum and the telocoroidea, ventrally by the quadrigeminal plate and midbrain tectum, rostrally or cranially via the posterior aspect of the third ventricle, and caudally by the cerebellar vermis. So just some key facts about the pineal glands I mentioned before. Main hormone secreted is melatonin. The functions being maintaining the circadian rhythm. Also has a part to play in sexual and reproductive development too. How patients present with these types of tumors. So almost all patients have hydrocephalus by the time of presentation, causing the typical signs and symptoms of headache, vomiting, lethargy, memory disturbance, abnormally increase in head circumference in infants, and seizures. They can present with symptoms of Paranoid syndrome, which is the triad of nystagmus, upward gaze palsy, and diplopia, or the syndrome of Sylvian aqueduct may be present. Some patients may present with precocious puberty, and that can occur only in boys with choriocarcinomas or in germinomas with syncytial trophoblastic cells due to the luteinizing hormone-like effects of beta-ATG secreted in the CSF. In the case of the supracellular germ cell tumors, you could have the triad of diabetes insipidus, visual deficits, and pan-hypopituitarism. You can also have drop metastases from the CSF seeding, and that could produce radiculopathy and myelopathy. And this is just a table like summarized the many different ways that patients can present with these tumors. You could just go through that in your own time. And moving on to the classification. So majority of these tumors tend to be germ cell tumors, comprising about 40 to 65% of all tumors. The second most common being the pineal parenchymal tumors. Then we have the others like the glial cell tumors, which comprise the 15 to 25% of these tumors, and miscellaneous tumors and cysts, which I wouldn't really get into, but coming down to the end of the presentation, I'll touch a bit on pineal cysts. Each category of these tumors, they have a continuum from benign to malignant, and mixed tumors, meaning tumors that have more than one cell type, can also occur. This is just a little flowchart showing the different types of pineal region tumors. So we can further subdivide it into germ cell tumors. Germ cell tumors being your germinomas with syncytial trophoblastic component. Your non-germinomatous germ cell tumors and teratomas. And then you have your pineal parenchymal tumors, in which you have your pineocytomas, pineoblastoma, your pineal parenchymal tumor of intermediate differentiation, and your papillary tumor of the pineal region. And then you have your uncommon ones, which we wouldn't really discuss in this presentation. So your pineal germ cell tumors. In the US and Europe, the germ cell tumors represent about 0.5 to 3% of your pediatric CNS tumors. In Asian countries, they represent up to 11% of pediatric CNS tumors. They have a peak incidence at the ages of 10 to 12 years old, with germinomas commonly present in older patients and the non-germinomatous germ cell tumors in younger patients. It also shows a male predominance as well. So germ cell tumors, as seen in the picture before, they're broadly categorized into germinomas and non-germinomatous germ cell tumors. Your non-germinomatous germ cell tumor types include endodermal sinus tumors, or also known as the yolk sac tumor, choriocarcinoma, embryonal carcinoma, and mixed malignant germ cell. Then you have your teratomas, which can be immature, mature, or it can be with malignant transformation. And this is just showing like how these tumor subtypes come to be. So you have your precursor cell, which is your totipotent primordial germ cell. And if it undergoes normal differentiation, you could have just a normal pineal gland. If it undergoes somatic differentiation, you could have a teratoma developing, which can be mature, immature. If it's embryonic differentiation, you get your embryonal carcinoma. If it's extra embryonic, you can have your yolk sac tumors or choriocarcinomas developing. Or if it doesn't undergo any type of differentiation, it could just strictly be a germinoma. With respect to pineal germinomas, so these are the most common tumor of the pineal region, accounting for approximately 50% of all tumors, and the majority, approximately 80% of all intracranial germ cell tumors. There's a marked male predominance with a male to female ratio of 13 to 1. Most patients are 20 years or younger at the time of diagnosis. So they originate from totipotent primordial germ cells, and they are analogous to the germ cell tumors arising in the gonads as well. There may be elevated CSF, placental alkaline phosphatase, and human chorionic gonadotrophin, HCG. So germinomas are composed of cells with large nuclei and prominent nucleoli. Lymphocyte infiltration is a common feature, although the degree varies from case to case. The two main tumor markers that are followed in intracranial germ cell tumors are alpha-fetoprotein, which is synthesized by the yolk sac, and human chorionic gonadotrophin, synthesized by the chorioepithelium. In the case of germinomas, usually neither AFP or ATG are useful in aiding preoperative diagnosis, but for monitoring following treatment. Here we have a CT image of a pineal germinoma. So usually CT would be the first investigation that would reveal some type of abnormality, except in the case of like mature teratomas, which often demonstrate fat density. It cannot reliably, well, a CT cannot reliably differentiate between different types of germ cell tumors. Although as a general rule, germinomas are more homogeneous in appearance than non-germinoma germ cell tumors. General features of intracranial germ cell tumors include, so they are hyperdense compared to the normal brain. They vividly enhance with contrast and calcification. So in the majority of cases, they usually represent engulfed normal pineal calcification as well as sometimes tumor calcification. On MRI, so general imaging features include on the T1 scan, it is iso-intense to the gray matter of the brain. On T2 can be similar as well. On a T1 scan with contrast, it vividly enhances with contrast. On DWI, restriction is common, especially for germinomas due to high cellularity. The ADC values are higher than that found in a pineoblastoma. And on SWI, hemorrhage is common in the non-germinomatous germ cell tumors. And this is just a table that basically summarizes the different types of germ cell tumors in the topmost columns with the demographics, like at what age or decade of life tumors may present, as well as a summary on the imaging findings. Later on, we'll get into the pineal parenchymal tumors. How do we manage pineal germ cell tumors? So it's important to measure your markers, particularly in the CSF and the serum. So namely, the alpha-fetoprotein and beta-HCG are secreted by non-germinomatous germ cell tumors or immature teratomatous elements and can be detected both in the serum or the cerebrospinal fluid. So these markers can be used to diagnose non-germinomatous germ cell tumors, even without tissue confirmation, thereby avoiding surgery at presentation and its associated complications. Markers can be used to reflect prognosis, evaluate response to treatment, and to monitor disease recurrence. And this is a table showing the degree of elevation of each of the types of tumor markers that these tumors can secrete. Personally, I like this little flowchart in this slide here. So it shows, for example, you have your beta-HCG, your alpha-fetoprotein, and placental alkaline phosphatase. So if any of these are positive, like in the case of beta-ATG, it's most likely a choriocarcinoma. If it is producing alpha-fetoprotein, it can either be a yolk sac tumor, immature teratoma or embryonal carcinoma, both of which are your non-germinal germ cell tumors. Or if it is a tumor that produces a high degree of placental alkaline phosphatase, is most likely a germinoma, which falls under your germ cell tumors. If uh, if the tumor markers are negative, it can either be a teratoma, which can be mature, immature, or it can be a pineal parenchymal tumor. Um, in terms of endoscopy, so the introduction of neuroendoscopy has helped improve the mobility and mortality of procedures in the pineal region. For patients presenting with obstructive hydrocephalus, the initial management is endoscopic third ventriculostomy, or ETV, inspection of the ventricular system for evidence of CSF dissemination, and biopsy of the tumor if technically feasible, along with CSF sampling for your cytology and your tumor markers. ETV should be the first line of treatment for obstructive hydrocephalus in patients with tumors in the pineal region. However, if this is not available, you can do placement of a ventriculoperitoneal shunt. This could be performed initial management of hydrocephalus, but it does carry the risk of peritoneal dissemination. This is just an image showing a sagittal T1 MRI. On the left, you could see the flow of the third ventricle after ETV has been performed. And on the right-hand side, you could see a pineal region tumor obstructing the aqueduct of Sylvius. The role of chemotherapy, radiation, and combination therapy. So the germinal germ cell tumors are highly radiosensitive, and therefore they can be treated with radiotherapy alone. However, in order to reduce the long-term side effects of radiotherapy, you could also do adjuvant chemotherapy. This has been shown to lower the needed dose and feel of radiotherapy while achieving favorable outcomes. In terms of the non-germinal germ cell tumors and teratomas, with the exception of the mature teratoma, these are more aggressive tumors, so management usually incorporates a combination of chemotherapy followed by craniospinal irradiation or CSI. In contrast, management of mature teratomas can be through surgery alone if gross total resection is achieved without the need for adjuvant therapy. And mixed germ cell tumors, these are managed according to the most malignant component present in the tumor. With advancements in endoscopic neurosurgical procedures and stereotactic biopsies, and the ability to reach a diagnosis by markers, the role of open surgery to obtain a tissue diagnosis has declined. However, if tumor resection of the bulkin is indicated after tissue diagnosis, open surgery is still a viable option. Several approaches can be used to access the pineal region, including interhemispheric, transcallosal, suboccipital transtentorial, and supracerebellar infratentorial. But these approaches are determined by the surgeon's preference, the risk of morbidity the tumor carries, and the tumor location. And this is just a diagram showing all the different types of approaches that can be taken when dealing with these kinds of tumors, depending on the location and the surgeon preference, of course. We move on now to the pineal parenchymal tumors. So the first one we have is the pineocytoma, which is a WHO grade 1 type of tumor. It is rare and well differentiated and consists of pineocytomatous rosettes of uniform cells and/or pleomorphic cells having gangliocytic differentiation. These kind of tumors typically affect adults. The average age of diagnosis around 43 years. It comprises approximately 20% of all pineal parenchymal neoplasms and are found exclusively in the pineal gland. It is not disseminating or infiltrating. The 5-year survival rates for these types of tumors are 86 to 91%. On CT imaging, it demonstrates pineocytomas to be of an intermediate density, similar to the adjacent brain. Pineal calcifications tend to be dispersed peripherally. This is the same pattern seen in other pineal parenchymal tumors, which is helpful in distinguishing these tumors from pineal germinomas that tend to engulf pineal calcification. And MRI is the modality of choice for examining any tumor of the pineal region. On the T1 scans, these tumors are hypo to iso-intense to brain parenchyma. On T2, the solid components are iso-intense to brain parenchyma, with areas of cystic change being common, although sometimes the majority of the tumor can be cystic. And on contrast scans, the solid components vividly enhance. And this is just showing other views as well, say axial view, your coronal view, and sagittal view as well. Histology of these types of tumors. So under light microscopy, pineocytomas are composed of small cells similar in appearance to normal pinealocytes arranged in sheets. Pineocytomatous pseudorosettes are characteristic, and they are not seen in normal pineal gland tissue. As is the case with the rest of the pineal gland, pineocytomas do not have a well-formed blood-brain barrier, and as such, they enhance vividly with contrast. In keeping with their low grade, mitotic figures are rare. We move on to the pineal parenchymal tumor of intermediate differentiation, which is classified as a WHO grade 2 or grade 3 type of intracranial tumor. A pineal tumor. It is a pineal tumor with varying degrees of clinical and biological behavior that's intermediate in malignancy between pineocytoma and pineoblastoma, and consists of monomorphic round cells that appear more differentiated than those of pineoblastomas, and they are arranged in sheets or lobules. The mean age of diagnosis for these types of tumors is around 41 years of age. Lower grade versions demonstrate frequent and local delayed recurrence, but higher grade lesions, however, can produce craniospinal mets. The 5-year survival ranges from 39 to 74%. On histology, these types of tumors show densely cellular. It forms diffuse sheets as well as perivascular pseudo-rosettes. Homarite rosettes are absent. The tumor cells have increased nuclear to cytoplasmic ratio with enlarged round nuclei, small nucleoli, and scanty cytoplasm. No necrosis is seen, and there are about 10 mitoses per 10 high power fields. Then we have the pineoblastoma. So this is a malignant WHO grade 4 poorly differentiated embryonal pineal tumor. They comprise of small immature neural epithelial cells having a high nuclear to cytoplasmic ratio, hyperchromatic or like darkly staining nuclei, and a paucity of cytoplasm arranged in sheets. They constitute approximately 30% of pineal gland tumors. The mean age of diagnosis is younger, so adolescent years 17, 18, than the less malignant counterparts. But the clinical course of these are much more aggressive, with CSF mets being very common. The 5-year survival rate is around 10 to 81%. The reported median survival is around 4 to 8 years in recent studies. Poor prognosticators for these types of tumors include having disseminated disease at the time of diagnosis, as evidenced by positive CSF cytology and/or spinal MRI, young patient age, and partial surgical resection. And radiation therapy appears to be a very helpful adjuvant therapy to surgery. On CT, the solid components of these tumors tend to be slightly hyperdense compared to the adjacent brain due to the high cellularity. Classically, that is described as having peripherally dispersed or exploded calcification. A good mnemonic to remember these types of tumors are blasted calcification, similar to pineocytomas. In contrast, as mentioned before, pineal germinomas tend to engulf pineal calcification, when in the case of these tumors, the calcification is more dispersed. On MRI, pineoblastomas tend to appear sizable, so around more than 4 centimeter irregular masses, often with evidence of invasion into the adjacent brain. Typical signal characteristics include on the T1, they are iso-intense to hypo-intense to adjacent brain. On T2, they are iso-intense to adjacent brain, with areas of cyst formation or necrosis being present, and they vividly enhance with contrast in a heterogeneous way. On DWI and ADC, so there's restricted diffusion due to dense cellular packing, and ADC values are typically approximately 400 to 800. Central necrosis is sometimes present, which can make the mass appear centrally cystic. So it could actually roughly mimic a pineal cyst, although pineal cysts should have a smooth, thin wall. And in the case of these tumors, it's important to screen the whole neural axis, as CSF seeding is seen in 45% of cases. This is showing different views. So your axial, your coronal, and sagittal views of a pineal blastoma here. On histology, so as mentioned, they are densely cellular. It is composed of tightly packed small round blue cells with a high nuclear to cytoplasmic ratio. And the growth pattern is largely featureless, with the pineocytomatous rosettes not present. You may see Homerite and Flexner Wintersteiner rosettes, with areas of necrosis frequently encountered and a high mitotic rate. And finally, we have the papillary tumor of the pineal region, which falls under WHO grade 102 type of tumor. So it is a pineal region neuroepithelial tumor with papillary and solid areas with epithelial-like cells and immunoreactivity for cytokeratins. These tumors usually affect children and adults. The mean age of diagnosis around 35 years. Recurrence is common, but mets are pretty rare. The 5 and 10-year survival rates are about 73%. And this is just an MRI showing what these tumors look like. So they are typically well-defined with variable T1 signal, high T2 signal, and heterogeneous post-contrast enhancement, and they without pathognomic features. You can see cystic areas within the mass being commonly seen. On histology, the papillary tumors of the pineal region, they demonstrate variable morphology, so they can range from solid to predominantly papillary, reminiscent of ependymomas, including the presence of ependymal rosettes, with areas of necrosis sometimes being identified. How do we manage pineal parenchyma tumors? So, in the case of pineocytomas, they are primarily treated surgically. Asymptomatic pineal parenchymal tumors can be managed conservatively, but if they are enlarged and symptomatic, then gross total resection is generally curative. For those with subtotal resection, postoperative radiotherapy is administered. In the case of pineoblastomas, these are highly aggressive tumors that require surgical resection, as well as combination craniospinal irradiation, tumor boost, and chemotherapy. For pineal parenchymal tumors of intermediate differentiation, the treatment is dependent on the degree of invasion in the brain. Disease that is limited locally can be treated with surgical resection alone. If it is locally invasive or disseminated disease, is treated with resection, craniospinal irradiation, and chemotherapy. And lastly, papillary tumors of the pineal region are typically treated with resection, radiation, and chemotherapy. They frequently recur, but craniospinal irradiation has been shown to be effective in both initial management and at recurrence. Some suggestions when approaching any kind of pineal tumor, it's important to perform an MRI of your cervical, thoracic, and lumbar spine to assess for drop mets. You can send for your germ cell tumor markers, say beta-HCG, alpha-fetoprotein, and placental alkaline phosphatase. These are helpful, but not always adequate for diagnosis. For example, if they're negative for germ cell tumor markers, it can be a pineal cell tumor, or maybe a germ cell tumor without markers. If your tumor markers come back positive, it can also be a mixed cell type tumor. And you want to obtain these markers from your CSF and your serum. If by chance you opted to do an EVD, you can get your CSF sample from that. You want to obtain histology in most cases. So this would include getting a biopsy, which should be generous to avoid missing other histology in mixed cell tumors. If hydrocephalus is present, you want to do your transventricular biopsy. If there's no hydrocephalus, you can go ahead and do your open biopsy or a stereotactic biopsy. Based on your markers and histology, so just to summarize, in germinomas, these are highly radiosensitive, so you can treat with radiation plus or minus chemotherapy. All other tumors, one option is resection, followed by adjuvant therapy. And this is just an algorithm for the step-by-step management of pineal region tumors. I have two algorithms. I personally like this one. So this one, it begins with when you do your MRI. If, for example, the tumor shows features of a teratoma, if there's hydrocephalus present, you do your CSF diversion via your ETV or shunt, and you obtain your tumor markers via CSF and serum, and do your surgical excision to get your biopsy to send to pathology. If the pathology returns a mature teratoma, that's marker is negative, you just provide follow-up. If your pathology returns with an immature teratoma or a teratoma with malignant transformation, with markers that are positive, you treat with radiation and chemotherapy. If in the case of an MRI with features of teratoma, but you find that hydrocephalus is absent, you just obtain your serum and CSF markers. You do your surgical excision to get your biopsy, to make a tissue diagnosis. And if it is, you get your mature teratoma with markers negative, provide follow-up. If you get your immature teratoma or a teratoma with malignant transformation, markers positive, radiation and chemo. In the case of MRI without features of a teratoma and you have your hydrocephalus present, you do your ETV, obtain your biopsy, get your serum and CSF markers. If it returns as a germinoma, then automatically these tumors are radiosensitive, so you do your radiation with your chemotherapy. If it comes back as a non-germinomatous germ cell tumor, you do your radical resection and radiation therapy and chemo. If it shows up as features suggestive of a pineal parenchymal tumor, you do your radical resection plus or minus radiation or chemo. And the same is repeated here as well in the case of hydrocephalus being absent. If your serum and CSF markers are positive, radiation and chemo. If your markers are negative, you do your surgery, you get your biopsy. Sorry, you do a intraoperative pathology consultation, where if the tumor shows features of germinoma, you do radiation and chemo. Your non-germinomatous germ cell, resection, radiation, chemo, and your pineal parenchymal tumors, resection plus or minus radiation and chemotherapy. And lastly, I just want to touch a bit on pineal cysts. So pineal cysts are actually pretty common, although asymptomatic. They are typically found incidentally on scans. The importance is mainly in the fact that they cannot be distinguished from cystic tumors, especially when large or atypical features are present. As such, many patients undergo prolonged follow-up for these lesions, presumably with associated anxiety. They generally present as a unilocular cyst within the pineal gland, where attenuation of fluid signal may vary from similar to CSF to around 60% being slightly hyperintense to CSF on T1 weighted images. Pineal cysts, they usually show a thin, smooth rim of contrast enhancement, and calcifications are present in 25% of instances. Pineal cysts are typically found in young adults, around 20 to 30 years of age, with a predilection for women, 3-to-1 female to male ratio. They're seen in approximately 5% brain MRIs and 20 to 40% of autopsy series. In high-resolution MRIs, there was a study that found a high prevalence of asymptomatic cysts in 23% of healthy subjects. How these cysts present, so the vast majority of them are pretty small, less than 1 centimeter, and asymptomatic. When they are larger, however, they can present with mass effect on the tectile plate, leading to compression of the superior colliculi and leading to symptoms of paranoid syndrome. If the cerebral aqueduct is compressed, they can also result in obstructive hydrocephalus. And very rarely, hemorrhage into pineal cyst can cause rapid expansion and so-called pineal apoplexy. This is just an MRI showing a pineal cyst. On a T1 scan, they're typically iso to hypointense compared to the brain parenchyma, with 55 to 60% somewhat hypointense when compared to CSF, and they're usually homogeneous in signal. Whereas on the T2 scans, they show a high signal, usually slightly hypointense to CSF, and you may be able to see thin septations or small internal cysts. And this is just your MRI. You can see a sagittal T1 non-contrast showing a cyst. This is an axial T1 non-contrast showing a pineal cyst, and also being demonstrated on an axial T1 with contrast, as shown by the yellow arrowhead here. The management of pineal cysts, so asymptomatic ones that are less than 2 centimeters in diameter, with a typical appearance where it was less than or equal to 2 millimeters thick, no irregularities or nodular enhancement. They are generally considered not to grow, but the natural history is not known with certainty. The risk of growing is approximately 4% with 6 months median follow-up in adults and 11% in children with 10 months median follow-up. So based on this, it seems also hard to justify not providing follow-up to reassure the patient and the practitioner. A reasonable approach to the cyst, to follow up on the cyst, you can do a 3-month follow-up MRI after the initial scan to check for rapid growth, as might occur with a neoplasm. If stable, you can do annual imaging studies for arbitrary period. Some suggest 1 year. 3 years is probably a reasonable figure to show stability. If you have a symptomatic cyst or one that shows changes on MRI, you would do surgery to relieve the symptoms and obtain a diagnosis. If the cyst presents with hydrocephalus, surgical options include CSF diversion. This is mostly recommended for lesions with the appearance of a typical pineal cyst, as it does not obtain tissue for pathology. It may not relieve the gaze disturbance from direct pressure on the tactile plate. You could also do, well, options for CSF diversion include a CSF shunt. You could do your endoscopic third ventriculostomy. A few cases of regression of pineal cysts after ETV have been reported. You could do aspiration via stereotactic or endoscopic approaches, although you may not get enough tissue for the diagnosis. Or you could do cyst excision via open or endoscopic approach, and that can relieve symptoms and establish a diagnosis. And that would conclude my presentation on pineal region lesions and pineal tumors. These are my references. I just want to thank you all for your undivided attention.